Good evening to all the faculties and delegates. I Amay welcome you all for the webinar titled Genitourinary Tumors Conclave 2022. With the permission of the organizers, we will start today's proceeding. I invite Dr. Ankita Jain, Director, Medical Affairs, Oncology and Field Medical Pfizer. Over to you, Dr. Ankita.
Thanks. Good evening, everyone. And on behalf of the Pfizer Oncology Medical Team, it's my pleasure to welcome you all to the Genitourinary Conclave 2022, a meeting dedicated for discussion on recent advances and latest updates in the field of urothelial cancer and renal cell carcinoma. This meeting, as you know, is scheduled over 2 days with an impressive scientific agenda and is graced by presence of eminent international and national faculty. I would like to invite Dr. Malhotra sir, you, and Dr. Malhotra needs no introduction to this audience. However, just to formally introduce, Dr. Malhotra is presently the Director Oncology Services, Sri Ram Cancer and Super Specialty Center, and Professor and Head of Department, Medical Oncology, Mahatma Gandhi Medical College and Hospital, Jaipur. Sir, pleasure to have you today, and over to you.
And thank you very much, Ankita. My pleasure, privilege, and honor to be part of this activity. And let me, on my personal behalf, welcome you to this conclave on genitourinary tumors. And we will cover all aspects of genitourinary tumors over 2 days. So initial apologies to all of you who are attending this, at the last minute, even after all best preparations. Some of the other technical glitches can and do happen. And our first speaker, Dr. Meenu Walia, she has some audio issues. So with the permission of everybody, we will switch the speakers in the interest of time. And it is a real pleasure to invite Dr. Thomas Powells to give the first talk. Dr. Powells is Professor of Genitourinary Oncology and Director at the Bart's Cancer Center, St. Bartholomew's Hospital in London. And I may also add that Dr. Powells is one of the top Euro medical oncologists in the world. And I had the privilege of interacting with him when we formulated the Asia Pacific guidelines for prostate cancer just about a month back, and that document is now ready to be published, and we are waiting for it to be published. So, Dr. Thomas, thank you very much for being part of this program and for permitting us to shuffle the sequence of your talks. And we are very eagerly waiting for you. And I'd like to now invite Dr. Powells for his talk. And he is going to talk to us on challenges in selecting first-line therapy for urothelial cancers. So over to you, Dr. Powells.
Oh, thank you very much, and I hope you can hear me clearly. Firstly, I'd like to thank you for inviting me to this presentation in India. I'm going to be talking in broad terms about the disease. If someone could put my slides up on the screen for me and move them on, that would be great. The story of urothelial cancer as it currently stands is one of drug development which have paused for many, many years with the development of gem-cis and gem-carbo chemotherapy. After that period, we developed a series of immune therapies. Those immune therapies actually have been quite successful, but their success is mainly based around two principles. The first is we have long-term durable remissions, which we've never really had before. And that's very exciting in urothelial cancer. The second is we know that the immune therapy does not work well at getting initial control of disease. And in most patients, their cancers progress. And unfortunately, we haven't developed successful biomarkers to predict the use of these treatments. And so essentially, we're currently in a position where we like the fact that we've developed a new class of drugs. We accept they're almost certainly better than the drugs we've developed before, particularly drugs like chemotherapy. However, if you just hold the slide there, that would be great. We're not quite there yet. I'll ask to move the slides forward when we can. However, we're not quite in a position yet where we can say we know in whom the treatment works. So what I'm going to outline in my presentation today is three important factors. Number one is, how do we select patients for first-line therapy? Number two, in the knowledge that we can select patients for first-line therapy, where is the best place to use these drugs? If you could move to the next slide, that'd be great. So this is my first slide, and this is an important slide. Essentially, what it tells us is that we have a situation at the moment where we have defined patients based off their platinum eligibility. And what does that mean? Well, platinum eligibility is not around tumor factors. Platinum eligibility is based mainly around this key issue of renal function and performance status. The fact that people feel or say that immune therapy only works well in platinum ineligible patients is probably flawed. And the reason why it's flawed is that it appears that the drugs work equally well in platinum eligible and platinum ineligible disease. However, we developed this treatment algorithm initially, probably 5 years ago, based off two small trials looking at atezolizumab and pembrolizumab in this setting. And what that essentially showed was that both drugs essentially were good at getting long-term durable responses, but unfortunately, that was only in a minority of patients. And so where we are at the moment is we looked at this data and we waited for the randomized trials. Can we move to the next slide, please? These are the randomized trials that we performed. There were three groups of studies. The first on the far right is the immune therapies alone. In the middle is the immune therapies and the chemotherapies together. And on the left is sequencing chemotherapy and immune therapy, the Javelin 100 approach. And you will be aware that in the key pivotal randomized trials, the chemotherapy, immune therapy combinations was unsuccessful. In fact, they were antagonistic together. The single agent immune therapies were not good enough at getting control of disease, and the biomarker didn't select those patients that benefited. And so therefore, we were left with this maintenance approach, which showed a 30% reduction in the risk of death associated with sequencing chemotherapy. Immune therapy. Can we move to the next slide, please? If we can move to the next slide, that'd be great. And so this is the next slide, and this is a really important slide, because what this tells us is that single agent durvalumab in red, in dark red, is unable to beat single agent chemotherapy or chemotherapy doublet treatment with GemCis or GemCarbo, even in the biomarker selected population. Why is that the case? This is for two reasons. Number one, the response rate for immune therapy is only about 20%. It's more like that the biomarker, the PD-L1 biomarker, did not select the winners. And the conclusion of Danube, of 361, and indeed of 130, that tested durvalumab, atezolizumab, and pembrolizumab, overall showed that chemotherapy, GemCis or GemCarbo, outperformed immune therapy in this population. Can we move to the next slide, please? And the next slide. And here we get an idea of the combination of chemotherapy in green, single agent immune therapy in red. And provocatively, I have concluded the durva-tremi, the CTLA-4 PD-L1 combination in this trial. And what we can see from this is actually higher response rates associated with the combination than the monotherapy. And there is still hope that the combination, the immune combination, will turn out to be successful in the future. But as it currently stands, we're not in that position. Can we move to the next slide, please? This is a provocative slide from the Spanish group. And essentially what this shows us is that in blue, we have 2 cycles of avelumab followed by chemotherapy. And in red, we have chemotherapy alone. And look at the difference between these 2 arms. We can see clearly a significant benefit associated with giving chemotherapy first rather than giving immune therapy followed by chemotherapy. And why is that the case? Well, the answer to the question is immune therapy is simply not good enough at getting initial control of disease. If we could move to the next slide, that would be great. Thank you very much. This slide shows us the combination of chemotherapy and immune therapy together. And you can see from this slide that the combination of chemotherapy and immune therapy is less effective than is equally effective as chemotherapy alone in this setting. Why is that the case? Just give me 1 second. And the reason we've seen this is because chemotherapy alone is not associated with a synergistic interaction when we combine this with immune therapy. Can we move to the next slide? This slide here shows the chemotherapy, immune therapy combination together. And this slide's important because what it shows us is there is no significant increase in response rates associated with a combination of chemotherapy and immune therapy together. The problem with this combination, which I think is quite telling, is that if we don't have this synergistic interaction, we've got a serious problem on our hands if we're going to use combination approaches. And indeed, what we've shown with this particular combination in urothelial cancer is chemotherapy and immune therapy together have not been successful. We don't know why that's the case. Some people say it's because of the type of chemotherapy that we use. Other people feel there's something unusual with bladder cancer. Could we move to the next slide, please? It's my feeling that we can find synergistic combinations in the future, but this is not the way to do it. The next slide shows us single agent atezolizumab in this setting. And essentially, what we have with single agent immune therapy is these long-term durable remissions. But this slide was very confusing. And the reason why this Nature publication was confusing was the PD-L1 positive patients, the green patients in this waterfall plot, seem to do much better than the red patients, the PD-L1 negative patients. If we can move to the next slide, that'd be great. On the next slide, we actually see the detail associated. If we can move to the next slide, that'd be great. On the next slide, we can actually see the detail of this PD-L1 biomarker. And essentially, what the biomarker shows us is that we have a series of different PD-L1 biomarkers. There is no such thing as a single PD-L1 biomarker. There are multiple biomarkers, and these biomarkers are defined by different tumor cell staining, different immune cell staining. They're defined by different antibodies and different percentage positivity. And in fact, there are an infinite number of definitions of PD-L1 positivity. However, there is one consistent finding, and that consistent finding is the PD-L1 biomarker has always been negative when we've prospectively tested it. Most recently, we've done a trial called 901. That is the IPI-NIVO trial of ipilimumab and nivolumab together. And that combination has not shown a benefit either. So I can tell you now that the PD-L1 biomarker is not fit for purpose. Let's move to the next slide if we can. On this slide, I previously said that in my opinion, there is no big difference between GEM-CIS and GEM-CARBO. This is a subset analysis from the Danube trial. This compares GEM-CIS and GEM-CARBO in this population. And what you can see here is very similar outcomes for these two populations. Essentially, what it means, very simply, is that while we all accept that chemotherapy doesn't work well, particularly gem-carbo, actually, gem-cis is not a lot better. What does this mean for the future drug development? Well, what it means is that we are better off giving chemotherapy first because it's better at getting control of disease. We know immune therapy is effective in subsets of patients, but for many patients, second-line immune therapy is too late. And so therefore, there was a desire to look at a separate approach, which is where the Javelin program becomes relevant. This indeed is the overview of the Javelin trial design. And what you can see from this is you can see a patient population of 700 patients who are randomized 1-to-1 to receive avelumab or best supportive care after 4 cycles of gemcitabine and cisplatin or gemcitabine and carboplatin chemotherapy. It's important to note that we didn't include those patients that have primary progression of disease on treatment. Those patients that progress would be ineligible for this trial because best supportive care is not a standard of care for second-line therapy. So those patients would have gone on to get pembrolizumab or atezolizumab or other agents. What the results of this trial showed us is a significant survival advantage. And this is now the 30-month follow-up data, essentially 3 years of follow-up. And what we have is a 25% reduction in the risk of death associated with avelumab, and actually about a 50% reduction in the risk of progression associated with avelumab. Why has this trial worked so well? Well, it's because it has what I describe as a Goldilocks effect. And what that means is it's not too early. We know frontline immune therapy is not good enough at getting in control of disease. But it's also not too late. And what I mean by too late is second-line therapy. Many patients never get to second-line therapy. And second-line therapy doesn't work particularly well because often the cancer is growing quickly. Let's move to the next slide. This regime is associated with broad spectrums of benefit across broad subgroups of patients. I've been struck by the fact it seems to work irrespective of the type of chemotherapy, the response to chemotherapy, the type of metastasis, visceral metastasis or lymph node metastasis, and the PD-L1 status. PD-L1 positive and negative patients both seem to benefit. And this slide's important too, because some people say to me, well, is this data just a representation of patients not getting subsequent therapies? What happened to the control arm in this trial? And you can see from this slide here, in the control arm, 73%, 72% of patients received subsequent therapy. And over half of these patients received subsequent immune checkpoint inhibition. And this is a really important finding. So we did a trial many years ago. It was called the LAM trial, where we looked at maintenance lapatinib. In that trial, only 20% of patients got subsequent therapy. Here we're seeing 70%. This is good news. Why is it good news? It means we're getting better at treating bladder cancer patients, but also, importantly, we can also see that immune therapy is now widely being used across the globe because this was a global trial. The adverse event profile for this drug is in line with expectations, with about 10% of patients having life-changing toxicity, about 10% requiring discontinuation, and about 10% stopping therapy. There were very few treatment-related deaths. I don't think there's anything unique about avelumab as a particular drug compared to other immune checkpoint inhibitors. Maintenance avelumab was not associated with a significant deterioration in quality of life. Of course, there are some flaws in the way we measure quality of life. Quality of life has got some significant problems. The way we measure quality of life is currently with different questionnaires. This is the EQ5D questionnaire, which asks 5 questions, broad questions, about how patients feel. And you can see from this that there's no big difference between the two. The reality is, for overall, there doesn't seem to be a difference. But for those 10% of patients who get significant toxicity, there is, of course, a significant difference between the two. I'm going to talk to you a little bit about the PD-L1 biomarker, if I may. So the PD-L1 biomarker is relevant here because we have spent a lot of time looking at it, and recently the EMA has approved the PD-L1 biomarker in the adjuvant setting. I think this is a hasty and an incorrect decision. I showed you a slide right at the beginning of my talk where I described PD-L1 positive patients who are cisplatin ineligible initially being recommended for atezolizumab or pembrolizumab. Those guidelines have had to change, and the reason those guidelines have changed is largely because the drug is deemed to be less effective in both populations in the frontline setting. The reason we've explored it in the Javelin trial is to work out whether it's the TC component or the IC component that appears to be more predictive. Our data, and other people's data contradicts this, suggests TC expression may be more relevant. The PD-L1 biomarker needs a great deal of work for the future, and when you combine PD-L1 status and TMB together, we don't seem to get better enrichment. And this is a real problem for the future. I think we've come to a point, in my opinion, where we should stop using the PD-L1 biomarker and find other avenues for biomarker selection in the future. I like this slide because the question that the last statement begs, if that is not the right biomarker, which biomarker should we use? And the answer to that question is it looks like that both innate and adaptive immunity are important in predicting responses to immune checkpoint inhibitors. And here we have data for innate biomarkers and adaptive biomarkers looking at both FOXP3, looking at CD8, looking at LAG3, but also looking at TIGIT, dendritic cell expressions, and other biomarkers as well. And this slide gives us an overview of innate and adaptive immunity. And you can see here, it's not just PD-L1 expression that's associated with response, but other key biomarkers as well. And these biomarkers include natural killer cells, macrophages, dendritic cells, as well as T and B cells. So in summary, I think it's fair to say that the predicting response to immune checkpoint inhibitors is much more complicated than we originally thought. And it should come as no surprise to us that PD-L1 in isolation is not good at predicting responders. This is another complexity in the biomarker issue, is I've talked about innate immunity and I've talked about adaptive immunity. Here, we show immune-independent biomarkers. We show angiogenic signatures, we show hedgehog signaling, and TGF-beta, all being relevant in predicting resistance to immune therapy. So when we look at the PD-L1 biomarker, we're ignoring the whole of innate immunity. We're also ignoring parallel factors, microenvironment, and stromal type factors, which are going to be important for the future. This is a study we're doing in the UK, France, and Spain. I wish India could take part. I would like somehow, by the way, and this is a discussion for a different day, but I'd like to find out how we can engage India more in the global development of clinical trials. India is such an important country to the global family, and we're not doing enough trials in India, in my opinion, at the moment. But this is a Western European study of 3 versus 6 cycles of chemotherapy, followed by maintenance of avelumab. And you can see from this slide here that the question is, do we need all 6 cycles of chemotherapy? As it currently stands, it is the standard of care. Although I have to tell you, for many of my patients, I feel it's too much treatment, and I probably stop early in about a third of our patients to a half of our patients do not get the full 6 cycles. And these are the ESMO guidelines. And actually, it's the left-hand side of this curve that's important. We're currently giving GemCis or GemCarbo with strong level 1A evidence. We then come down to maintenance of avelumab with level 1A evidence for those patients whose cancers have not progressed. Those patients whose cancers have progressed on chemotherapy should be getting pembrolizumab. And then at the third progression, or at second progression now, second line therapy is enfortumab vedotin. It's this triangle here which is really powerful. Chemotherapy, immune therapy, antibody drug conjugate. That is now the standard of care in advanced urothelial cancer. I'm just going to go through some enfortumab vedotin data, if I may. I'm going to talk a bit about the antibody drug conjugates. I know they're not globally widely available yet. We're beginning to use them in Europe, but I think they are going to make a major change for the future. EV301 is a randomized phase 3 study of enfortumab vedotin versus standard chemotherapy in unselected patients whose cancers have progressed after chemotherapy and avelumab or chemotherapy and pembrolizumab. It's a standard now second-line therapy, and here it's associated with a 30% reduction in the risk of death. This is an impressive environment. Remember, advanced urothelial cancer, pre-treated patients is a tough crowd, and this is a positive trial with a clear survival advantage. The drug's associated with a different toxicity profile. It's not the same as some of the other drugs you will have used. It has skin toxicity, particularly in the first 2 cycles. It's associated with peripheral neuropathy, particularly in cycles 4, 5, and 6. And it can also be associated with ocular changes and diabetes mellitus. Now, does this make it more difficult than chemotherapy? The answer is no. You can see here grade 3 to 5 adverse events occurring in approximately half of both chemotherapy and enfortumab vedotin patients. You can also see approximately 15% of patients in both arms having to stop therapy for adverse events. However, the adverse event profile of this drug is different. It's different for sacituzumab govitecan, and I'll come to that in a second as well. But we are going to have to do education and training around giving these drugs safely. And I like this slide, and I sometimes put this out on Twitter from time to time. I think what this slide is telling us is the PD-L1 immune component is not working well. The tumor component is also struggling now, particularly with the recent negative trial. Tumor mutational burden's never really been tested. Circulating tumor DNA looks really promising for the future, but we haven't finished our work there. And so, unfortunately, we really are some distance from personalized therapy with immune therapy in the future. Whether or not we can develop biomarkers for antibody drug conjugates, or indeed for FGF inhibition, is something that we're working on and actually making more progress with. I wanted to just talk about CTLA-4 very briefly. There are 2 global trials exploring CTLA-4. The original Danube trial would have been positive had we used the right endpoint. However, we used the ITT rather than the biomarker endpoint. This is a trial here, the Nile study. We've also seen the 901 trial. So while the ADCs are exciting, we haven't yet forgotten CTLA-4 as a potential target for the future. And indeed, I wanted to show you the ctDNA data today. This is patients after after a cystectomy, and those patients either getting placebo or best supportive care or adjuvant atezolizumab. And the high-risk population can be identified with circulating tumor DNA from a blood test. And indeed, those patients that are ctDNA positive have a 6-fold higher chance of relapse. And finally, of those patients, if we identify them early and we give them atezolizumab rather than best supportive care, their risk of death is reduced by 40%. This is a really important finding for the future. It's a really exciting finding, and we're trying to validate this in IMvigor011. This is another clinical trial that I'd really like to bring to India if we could. And certainly for those of you in the audience who are performing a lot of cystectomies, if you'd be interested in taking part in this trial, I'd really like to come to you. So what have I said today? Well, I think I've talked quite a lot, and I think it's been a broad talk about urothelial cancer. I think it's fair to say that immune therapy in the second-line setting is too late for most patients, and first-line immune therapy doesn't get in control of disease in enough patients. I think it's also fair to say that chemotherapy and immune therapy in combination doesn't work well in the first-line setting, and results of the PD-L1 biomarker have been disappointing. I think it's also fair to say that maintenance avelumab has become the preferred standard of care. This standard of care has level 1A evidence, it's widely used, and it's for a broad subgroups of patients whose cancers has not progressed on chemotherapy. I also hope I showed you in those last 5 slides some hope for the future. And I hope I showed you hope with a new class of drugs, the antibody drug conjugates. Also, I hope I showed you some new biomarkers which look really promising for the future. I'd like to thank you very much for your attention. I'm very happy to answer any questions.
Thank you so much, Professor Powells, and I think all of the audience would agree that this was a incredible talk by a truly top expert in the field. So, Ankita, how do you want to do questions? Can we do some questions for Dr. Powells, or do you want all the questions during the panel?
So we can take 1 or 2 questions now, and then rest we can take in the panel.
Okay, so anybody has any burning questions for Dr. Powells? The floor is open.
I'm very happy to answer any questions.
So, Dr. Powell, maybe I can start the ball rolling. We'll do only 2 questions, and let me pull rank and use my prerogative as chairperson to ask the first. So, my
Good for
question
you.
to you is, does the benefit of avelumab in the maintenance setting trump the potential toxicities of a patient who has say an immune disease or who's post hepatic transplant?
Yeah, so what a great question. So I think the question you're asking is there are subgroups of patients who historically we've defined as being ineligible for immune therapy. And what do we do with this group? I think the first thing to say is we're getting much more relaxed about treating this group. So there are groups of patients who have rheumatoid arthritis or autoimmune type diseases. And historically, we've not treated those. We've started treating this group of patients with actually some success. And it looks like patients who are not on steroids but have a history of autoimmune disease are not excluded from these therapies. It's important to remember in the adjuvant setting, the risk-benefit ratio is complicated. But advanced urothelial cancer, the outcome after chemotherapy, even in those patients that have a complete response, the median progression-free survival is only 4 months. So getting in control of this cancer with immune therapy is really important. And if these patients had, mild rheumatoid arthritis on no therapy for 10 years ago, that should not be considered an exclusion criteria. Renal transplant is more complicated. The reason why is clearly they're on immune suppressive drugs. If you're on immune suppressive drugs, the rationale for giving immune checkpoint inhibition therapy is complicated. However, I tend to avoid it for those patients who are on active immune therapy. And so patients with rheumatoid arthritis on methotrexate, I wouldn't be giving it. But autoimmune patients with transplants on temsirolimus or another immune-related suppressing drug, I'd be tempted not to do it. That's my personal preference. But we are giving this to much broader groups of patients than we were before.
So thank you very much. I think we will move on, and our next speaker is Dr. Meenu Walia. Meenu is a very dear friend, and to introduce her, she is the Director and Chief of Medical Oncology of several of the Max Cancer Institutes in Delhi. And Meenu is going to talk to us about current treatment landscapes for the first-line therapy of urothelial cancer. So, Meenu, I hope your audio videos are fine. We can see you very well, and I hope we can hear you too. So, you have 20 minutes. Please go ahead.
Yeah, thank you, sir. Thank you, and real apologies for the earlier IT hiccup. And I guess speaking after Dr. Paule, it's a huge challenge by the stalwart in genitourinary cancers. So I'll still try to do whatever I can. So, urinary bladder cancer, this was supposed to be the first talk. So, a brief intro about the epidemiology of the disease. All over the world, it ranks 10th commonest cancer. We know that it is much more common in men compared to the females. The incidence being 9.6 in men versus just 2.4 in the female, and mortality also 3.2 versus 0.9. So coming back to in our country, so all over the world it is the 10th commonest, but in India it is, I guess, much higher up. It is much more common. It is the ninth commonest cancer. The median age at diagnosis is around 59 years of age, and one third, as high as one third of our patients at the time when they present, they have either metastatic disease or locally advanced disease, and majority, as is all over the world, here also in our country, majority of the patients are males only. So it is the ninth commonest cancer as per our cancer registry, and 3.9% of all cancer cases are urinary bladder cancer. The commonest histology that is seen in our country to the tune of 1997 to 98% of the cases is transitional cell carcinoma. And this is one of the studies from DMH. The data that says is that almost 50% of the cases are either muscle invasive disease, locally advanced, or metastatic disease, and another 47% is non muscle invasive disease at presentation. So, what are the treatment guidelines for first line management, the systemic therapies for this group of patients, whether it is advanced or metastatic urinary bladder cancer? We know for all practical purposes, the patients needs to be divided into whether they are cisplatin eligible or ineligible. And the recommendation says that if it is cisplatin eligible, the cisplatin or the platinum backbone is very essential. So cisplatin based regimen, and the preferred agent is gemcitabine, which is a category 1 recommendation. NCCN also consider the dose dense MVEC regimen with adequate growth factor support as a category 1 recommendation, which is generally not covered with most of the European countries. For cisplatin ineligible, again, instead of cisplatin, probably carboplatin may carboplatin partner along with gemcitabine, or a patient who is PD-L1 positive. Yes, there is a strong role of immunotherapy also. And for any platinum ineligible, then irrespective of PD-L1, then IO has a role to play. Both Atizo and Pembro are approved in this setting. So, what are the recent, I will say, updated NCCN guidelines? So, these were the guidelines till last year, and the recent guidelines what do say is that, again, the initial thing that you need to decide about your patient is whether the patient is cisplatin eligible or ineligible. And if the cisplatin eligible, then as for what the earlier guidelines used to say, GEM-CIS be the category 1 recommendation. Here we have an addition, and that also says that if the patient does not progress, the patient has at least a stable disease after the first line therapy, then these are the patients which should be, there is a role of maintenance avelumab therapy. So whether the initial regimen was a GEM-CIS or the initial regimen was an MVEC regimen, this should be followed by avelumab maintenance therapy, and both are recommended by the latest NCCN guidelines. In cisplatin ineligible patient also, if the patient has received carboplatin, then also it is what is recommended is avelumab maintenance therapy, or a patient if PD-L1 positive or any platinum ineligible, we have recommendations for both Atizo or pembrolizumab. So maintenance therapy with avelumab is only recommended if there is no progression on the first line platinum based chemotherapy. So the patient should have at least a stable disease. That is what is recommended. So that was the NCCN updated, and again the ESMO guidelines. The European countries have also updated their recommendations, and we have level 1 category A recommendation of after platinum based chemotherapy in the first line for these treatment naive advanced metastatic urinary bladder cancers, role of maintenance avelumab therapy for all those who have not progressed on the initial platinum based therapy, irrespective of the fact that the patient was cisplatin ineligible and had received carboplatin based regimen, and irrespective of the fact that patient whether the patient was PDL1 positive or not. However, if the patient is platinum ineligible and PDL1 positive, then there is, yes, as you already mentioned, role of the other IO agents, atiso or pembrolizumab. So, maintenance avelumab is recommended in all metastatic urinary bladder cancers which have again not progressed. That is a very important point. The patient should have at least a stable disease on initial first line platinum based chemotherapy 4 to 6 cycles. So basically, an overview of the consensus of the same. The updated guidelines, both NCCN and ESMO, say the same thing. There is a definite role of maintenance therapy, whether cisplatin eligible or cisplatin ineligible, where carboplatin has been used, and NCCN also incorporates maintenance therapy after MVEC therapy. So, and this is irrespective of the PDL1 status, wherever we're talking of this maintenance regimen. Okay, and these updates were based on the Javelin Bladder 100 trial, where treatment with first line maintenance avelumab has been compared with best supportive care. And I'll be coming to that trial later. So this is what I think it has already been covered. What used to be the guidelines earlier. Historically, we know that we would only talk about cisplatin-based chemo regimens in these patients, all those who were eligible for cisplatin, not eligible for cisplatin, carboplatin-based regimens, and our previous guidelines used to recommend that in all those patients who were not able to tolerate these regimens, or we had nothing further beyond initial chemotherapy, active participation in clinical trials. Just there must be some postgraduates also in the audience. Just for a brief snapshot. So, what do we mean by cisplatin eligibility? So, we generally use Galsky criteria in our setting. So, for a person to be cisplatin eligible, ineligible or unfit for cisplatin, we generally consider a ECOG performance status more than equal to 2, creatinine clearance less than 60 ml per minute, hearing loss more than equal to grade 2, neuropathy again more than equal to grade 2, and heart failure, New York heart classification class 3 heart failure. So all these cases where it is difficult to give cisplatin makes the patient cisplatin eligible, and we need to find some other partner, either a carboplatin, or then also need to consider if the patient is having significant neuropathy, whether the patient is carboplatin eligible also or not. So again, a snapshot. So what is the first line standard of care for platinum eligible patients, whether they are locally advanced or metastatic urinary bladder cancer? We know that it is cisplatin or GEM plus either an MVEC regimen. However, how many of these patients we know? In case what we were used to do earlier is just give initial chemotherapy regimen and then wait and watch. But we know now from data that it is only 50% of these patients who receive who have received first line therapy will go on to receive the second line treatment also. And why is it that? This is again that out of these first line patients, generally most of the recommended maximum duration of treatment is 4 to 6 cycles only. Beyond 6 cycles, toxicity becomes a major concern. Longer duration of treatment is not recommended because of cumulative toxicities and lack of additional benefit. However, we did see whatever there were approximately 60 to 75% of the patients in all across the various randomized trials who seems to be achieving some kind of a response on initial platinum based therapy. So this is probably the subgroup that we are talking about, that what to do next for these patients. And as already mentioned, not all of them will be there to receive the second line therapy. So we knew with whatever is the data that tells us that with first line platinum based chemotherapy alone, the median progression free survival is to the tune of 6 to 8 months in spite of the responses. The overall response rate to the tune of 65 to 75%, the median progression free survival is only to the tune of 6 to 8 months, and the overall survival for majority of these patients were to the tune of 9 to 14 months only. And patients who had a poor performance status, the survival was much more less. So for the cisplatin ineligible, we have data from the keynote 052, where the other two IO agents that we talk about, one, this was for pembrolizumab. Can we have the study design? The next slide. So this was the study design. All those patients who were cisplatin ineligible, platinum ineligible rather, with advanced or metastatic urinary bladder cancer, they were given pembrolizumab 200 milligram Q3 weekly, and patients were followed up for almost 2 years. And the primary endpoint was overall response rate, along with secondary endpoints of duration of response in PFS and OS and safety analysis. So the groups were well matched, and what we found was that almost 24% of the patients that were treated had an objective response, and the disease control was achieved in almost 47% of the patient. So, and yes, a disease control was achieved in almost 47% of the patient, but the amount of disease control or the overall response rate was definitely much more, as depending on the PDL1. So CPS more than equal to 10%, the overall response rate was almost double than those patients who had a CPS 1 to 10%. So for 39% versus 20%, and this was further double than those who had a CPS less than 1%. So the amount of PDL1, the quantum of PDL1 positivity was also one of the factors that defined how much was the overall response rate. Similarly, the median duration of response was not reached in majority of the patient, and the median PFS was 2 to 3 months. Can we have, these were the secondary endpoints. Can we have the next slide? So PDL1 expression was an important parameter. PDL1 more than equal to 10%. Overall response rate was almost double, more than double, 47% versus 20% in PDL1 less than 10%. And with extended follow-up also, immunotherapy pembrolizumab continued to elicit clinically meaningful, and as was with other IO therapies. We have learned from all our experience that yes, the percentage of patients who respond to these immunotherapies may not be great, but whoever respond generally have durable responses. So in a similar fashion, even in this study, the anti-tumor activity was found to be, the responses were found to be durable responses, and especially more pronounced in those cases where the PDL1 expression was more than equal to 10%. So this was another IO, that is atezolizumab, again in a similar group of patient, and again a multicentric phase 2 trial. So this was IMvigor 210, a similar study, similar design. Here also patients who had received prior platinum therapy apart from that and progressed on that were also eligible for second line atezolizumab, a standard dose of 1200 milligram Q3 weekly. Again, the primary endpoint was similar to the keynote trial, overall response rate, and the secondary endpoint was overall response rate, duration of response, and PFS and OS and safety criteria. And again, patients were assessed, overall response rate was further assessed, categorized based on the PDL1 status, whether on tumor infiltrating immune cells, that was the higher the number of tumor infiltrating immune cells, possibly the percentage of responses was found to be. So this is again the OS. So at a median follow-up of almost 17 months, the median duration of response had not been achieved in invariably all of these patients. So again, highlighting the durability of responses, the median progression was free survival was almost similar, 2.7 months, that is 2 to 3 months, and the median overall survival in all these patients was 15.9 months. So this is what I wanted to say is with there are two options. Either we give first line chemotherapy, wait and watch, and once the disease progress, you go for the second line therapy. But we know that 40 to 50% of the patients never receive the second line therapy because at the time when the disease progresses, the disease is maybe really aggressive. So what Javelin has told us, the Javelin has told us that beyond first line, there is a definite role of first line maintenance therapy, and then if the disease progresses, then one can still think of something else beyond that. So yes, it is a far cry from that. And can we have a quick review of the next few slides? So immunotherapy, next please. So this was the data on which this study was designed, knowing that combination platinum based chemotherapy is the standard of choice in the first line treatment, and most patients will ultimately progress and not all of them are eligible for the second line therapy, and then that the only alternative for this is maintenance therapy. Can we have the next slide and go straight to the results? So this was the schema, and again, they were well matched, most of these patients. And again, what we do see is there was a overall survival benefit significantly longer in the those who received evolumab maintenance. So whether it was the overall population or it was the PDL1 positive population, again we can see the quantum of benefit is probably much more in the PDL1 positive population, where the median overall survival is not yet achieved at the time of this study as compared to but the benefit was there in the entire population. Again, so this was not only the OS advantage, we also had the PFS advantage, and again the quantum of benefit much more in the PDL1 positive population. So irrespective of the fact that this is just a forest plot explaining the same, irrespective of the fact that the patient was PDL1 positive or negative, first line irrespective of the fact which was the first line chemotherapy that was used, what was the site of metastasis, whether visceral or non-visceral metastasis, or the patient received a PR or only a stable disease as response to the previous therapies, all of these patients showed benefit to the addition of maintenance evolumab, again subgroup and further. So I would like to come straight to the my summary slide. So this advantage was not seen at the rate of increased toxicity, and invariably in those patients who did not receive maintenance, yes, the subsequent therapy we see, and almost half of them was immunotherapy in the second line, but even then the results were inferior. So can I go straight to the summary slide or conclusion? So what do we conclude after all these trials? The overall survival was much longer in the arm that received evolumab maintenance compared to those who did not. And first line maintenance evolumab therapy in patients with advanced urothelial cancer that have not progressed with platinum based chemotherapy seems to significantly prolong not only overall survival but also progression free survival. And that's it. That was it. Thank you.
Thank you very much, Dr. Meenu. That was a very, very nice talk. Going through the whole spectrum of treatments available for the urinary bladder cancer patients in the first line. So now after the first line treatment, will you please stay around? There might be some questions to you during the panel discussion. And thank you very much for a lovely talk. So we'll go now from the first line treatment to the treatment of refractory and advanced urothelial cancers. How do you sequence? What are the considerations and challenges? And the speaker for this is Dr. B.J. Srinivas. Dr. Srinivas is consultant medical oncologist at the HCG hospital in Bangalore. So Dr. Srinivas, you have 20 minutes and over to you. Thank you.
Yeah, thank you, sir. Thank you, the organizer, for giving me this opportunity. Yeah, listening to all the first line treatment and now coming on to the second line treatment. As our previous colleague has told, senior colleague has told that most of the patients coming onto the second line is very less. Chemotherapy followed by maintenance immunotherapy is the best treatment option. So some of the patients who have not received immunotherapy as a maintenance, so those progressed on the chemotherapy. So this is the keynote 045 study design, where patients progressed after platinum based chemotherapy or recurrence within 12 months or after therapy. They are randomized to pembrolizumab or the paclitaxel, dosi, and vinflunine. Though we usually don't use this in our clinical practice routinely. So these are the stratification factors, COG-B, HB, liver mets, time since, but there is no stratification according to the PDL1 CPS scoring. So treatment was continued 2 years or until progressive disease, and primary endpoint being the OS and PFS. So these are the endpoints. I mean, overall survival was around 10.3 months compared to the chemotherapy arm with a hazard ratio of 0.73, and median PFS was around 2.3, but P value was not statistically significant compared to the overall survival. PFS was not statistically significant. So overall survival in key subgroups all favoring the key immunotherapy arm compared to the chemotherapy in the second line setting. So, key overall survival in key subgroup also favoring the pembrolizumab arm, whether it is the liver metastasis present or not, the whether patient has received in the neoadjuvant setting or adjuvant setting, time since randomization, the investigator choice, whether paclitaxel, docetaxel, or vinflunine or previous platinum therapy. Most of the patients have responded to this immunotherapy in the second line. And 3-year follow-up are around 40.9 months. We can see here median survival of 10.1 months compared to the chemotherapy 7.2 months, and 24 months overall survival, that is 2-year overall survival, was 26.9% compared to 14.2, and even the 3-year overall survival is 20% compared to the 11% in the though we can see here the PFS is not beneficial, I mean is not favoring, but the overall survival which we require in most of our clinical studies, so this is more favoring the second line immunotherapy in patients who have progressed on the previous chemotherapy. So even the duration of response we can see here almost 30 months it is reaching, and the treatment related adverse events were almost the lesser compared to the chemotherapy arm. So coming on to the one more immunotherapy, atezolizumab, which is IM Vigor 211. So here also there is a metastatic or recurrent urothelial cancer who progressed on first line more than one or more than one line of platinum based therapy, and here physician chemotherapy and the atezolizumab. But here one of the stratification factor was the PDL1 expression. So that is immune scoring 1 to 5%, or if it is versus 1 to 5%, more than 5%, that is IC2 or bar 3. So like any other certification like chemotherapy, liver mets, and other also are present. And the primary endpoint being the overall survival in respect to the higher immune scoring versus immune cell scoring versus the lower immune scoring, followed by intent to treat population. So baseline characteristics were well matched, and here the progression-free survival we can see here the intent to treat population, that is the overall population, and the higher PDL1 percentage population. The median PFS is 2.4 months compared to the 4.3 months. And then objective response rate is around 113 compared to the 116, and best overall response is more favoring the in the higher atezolizumab group compared to the chemotherapy arm, and even the duration of response is also very much prolonged compared to the chemotherapy arm. So we can see here around median follow-up of 17 months in the intent to, in the IC23 population, the median overall survival is 11.1 months compared to 10.6 months in the chemotherapy arm, and objective response rates is also 23%, and the duration of response is almost doubled compared to 8.3 months in the chemotherapy arm. But in the intent to treat population, overall population, there is not much significance in the median overall survival in the 2 year or the 30-month overall survival. So second line, this is the like cross trial comparison. We can see here the immunotherapy, pembrolizumab and atezolizumab. In the pembrolizumab chemotherapy, the median overall survival is 10.1 months, whereas in the atezolizumab it is 11.1 months compared to the chemotherapy arm, and the 2 year overall survival is almost 26.9 months, and in the atezolizumab arm, especially in the PD-L1 positive population, 33 months compared to the chemotherapy arm. Though the pembrolizumab arm, there is no significant PFS benefit, and even in the atezolizumab arm, there is the PFS benefit is not there compared to the chemotherapy arm, and grade 3 to 4 toxicities were less compared to the chemotherapy. Coming on to the newer targeted therapies in second line or further later lines of therapy. So this is the FGFR alteration, which is present in 15% to 25% of 20% of the advanced urothelial cancer, and the mutation present in 37% of the upper tract urothelial cancer versus 22% on all urothelial cancer. And this is more common in low grade versus high grade urothelial cancer. And usually FGFR alteration occur in 7% of all tumor types. So usually around 15 to 20% of advanced urothelial cancer. So this is the one of the biomarker which after failure of first line and second line, we usually test it, and the patient can be put on these targeted therapy as per the clinical trial. So this is the phase 2 trial. Based on that, the erdafitinib has been approved for the patients who progressed on more than one line systemic chemotherapy, or within 12 months of neoadjuvant or adjuvant CT, or in patients with cisplatin ineligible, or patient who chemotherapy naive, and even prior immunotherapy also permitted. So this is the eligibility criteria for this trial, and there were 3 regimens with the different dosages: 10 mg per kg for 7 days, followed by 7 days on and 7 days off. Regimen 2 6 mg, and regimen 3 around 8 mg, and the treatment was continued till progression, and primary endpoint being the overall response rate. So this is the 40% of the patients have responded after in the second line or the third line setting, with the PR being the more commonest. So in April 2019, FDA approved this molecule in locally advanced metastatic urothelial cancer with FGFR3 or FGFR2 mutation or fusion that progressed during or after more than or equal to one line of platinum-contained treatment. So so we can see duration of type and the response with this plot. So PFS was around for all patients 5.5 months, and overall survival was around 11.3 months in patients with regimen 8 mg dosage cohort. And the treatment of specific interest, the side effects of specific interest with this molecule is hyperphosphatemia, stomatitis, nail events, and the skin changes, and the central serous retinopathy. So these are the things which we don't look with our other targeted therapies. So hyperphosphatemia and central serous retinopathies, that is what the commonest in the clinical trial, and no treatment related deaths were there, and most of the side effects were well manageable with the supportive therapy and dose modification. So these are the objective response. So I will not go into details in the interest of time. Next slide. So coming on to the antibody drug conjugate in the bladder cancer. So there were 2 anti-drug conjugate, enfortumab vedotin and the saxatumab govitecan. So the rationale for this is the most of the patients, around 20 to 30% of the patients can have nectin-4, a transmembrane cell adhesion molecule highly expressed in the urothelial cancer, which is a target for enfortumab vedotin. And whereas for the succinimab govitecan, so the targets the TROP2, an epithelial cell surface antigen highly expressed in the urothelial cancer. So both of the drug got a accelerated approval, especially for enfortumab vedotin for treatment of patients with advanced locally or metastatic urothelial cancer who received immunotherapy or platinum containing chemotherapy in the adjuvant, neoadjuvant or metastatic setting. And for the same indication applies for the succinimab irinotecan, whether patient has received immunotherapy, chemotherapy or the other biological therapy. So this is the EV301 phase 3 trial comparing the enfortumab vedotin and investigator choice of chemotherapy. The same inclusion criteria that patient progressed on chemotherapy or immunotherapy has been included. Primary endpoint being the overall survival. So we can see here with significant statistical significance, around 30% of the patient have benefited with this molecule in the patients who have received previously chemotherapy or the immunotherapy. And this is the secondary endpoints of PFS and overall objective response rate. PFS also is significant compared to the physician of choice, and there is a objective response rate of around 40.6% compared to the chemotherapy, which is around 18%. So here also there is a the side effects of special interest were skin rashes, like rash, severe cutaneous adverse reaction, peripheral neuropathy, and hyperglycemia, which we have to look for when we are using this molecule. So. So this is the cohort 2 patients, that is patients with patients who are cisplatin ineligible. So the cohort 1 is one which we have seen in the previous phase 3 trial, where platinum based patient failed on prior platinum based therapy or immunotherapy. So this is patients prior PD-L1 inhibitor, but a patient is cisplatin eligible. So whether so this the same dose has been used in this cohort 2 also. So here also waterfall plot showing the objective response rate of around 52%, and almost 88% of the patients had a decrease in tumor measurements from the baseline. And the PFS benefit is around 5.8 months, even in the cisplatin ineligible patients, and around 14.7 months in the overall survival benefit for these group of patients. So the second drug, anti-drug conjugate, that is sacituzumab govitecan. So this also there's two cohorts, whether it is a PD progressive disease after platinum and the immunotherapy, or cohort 2 with patients ineligible for platinum. The same dosage has been used in this cohort, and it has got accelerated approval in this group of patients. Primary endpoint being the overall response rate and duration of response, PFS, and the OS. So overall response rate, confirmed overall response rate were 31%, 27%. PR response were the 22%, and duration of response was 5.9 months. So it has and median TT were comparable to the investigator assessed outcomes in the, especially in the platinum refractory patients. So baseline characteristics were median age, ECOG PS, visual meds were there. So duration of response, we can see here duration of response is not reached. Median PFS is around 5.5 months. Median overall survival is 11.1 months. And so even in the platinum eligible or platinum refractory patients, so most of the patients have benefited in this group of with this group of molecule. So decrease in tumor size, almost 76% decrease. So patients with more than one are equal to one post baseline tumor measurement and accepted for central review. And most of the patients have responded to decrease in the tumor size with this succinimab govitecan. So response and survival outcomes in the platinum refractory patients. So most of the patients have responded with PR and the CR being the lesser, and PR is the most commonest response rates in this group of patients. So, because it is a chemotherapy, so neutropenia, hematological toxicities are more common. Some of the GI toxicities, because it is the irinotecan metabolite. So, diarrhea, nausea, vomiting is also seen all grades of tumor. Though the grade 3 were more common in the hematological toxicities, GI toxicities were less common in this with this molecule. Yeah, so the upcoming trials for second line and third line, even in the fourth line chemotherapy, fourth line urothelial cancer, especially with the antibody drug conjugate and combination of double immunotherapies and antidrug conjugate with the pembrolizumab. So these are the upcoming trials. So whether this antibody drug conjugate, whether it is beneficial in the patients with FGFR alteration or prior FGFR inhibitor has been used. So some of the retrospective trials are conflicting, where one of the trial has shown that patient who have received FGFR inhibitor and has been given this antibody drug conjugate has benefited, and some of the other retrospective analysis there is no such benefit. So this needs to be tested whether in the future randomized clinical trials. So this is the NCCN guideline, which prefers in the the second line therapy, especially the preferred regimen pembrolizumab category 1, and subsequent therapies being the antidrug body conjugate, that is enfortumab vedotin, and then patients with cisplatin eligible chemotherapy naive, so chemotherapy and the gemcitabine and cisplatin combination, and so these are the recommendations as per the NCCN guidelines. Yeah. So I think I have already told about this. So I think strategies for safety management with dafintinib, so especially the central serous retinopathy is the commonest one. So that is why there is some guidelines how to manage, and even the hyperphosphatemia. I will not go into details of this. And similarly, with anti-drug body conjugate, especially with enfortumab vedotin peripheral neuropathy, how to manage the side effect, and with saxatinib govitecan, I think when we are using, it will be more useful. I think with this, I will conclude my talk, and thanks the organizer for giving me the opportunity. Thank you.
So thank you very much, Dr. Srinivas. Very, very nice talk, and I think significant knowledge gain happened for all of us. Please stick around, be around during the panel discussion, and if there are any questions, we'll come back to you. So we'll move on. We're about 5 minutes late. Let's see if we can make that up. And the next speaker is Dr. Chirag Desai. Dr. Chirag has been a very dear friend for the past 4 decades. Can you believe it? He doesn't look that old. He looks still like a college student. But we've known each other for 40 years now, and it's a pleasure to invite him for the next talk. He is the director and senior medical oncology consultant at the Hematology Oncology Clinics in Ahmedabad. And Dr. Chirag is going to give us a snapshot of the conference highlights from ASCO 2022 and ASCO GU 2022. So over to you, Chirag. You have 20 minutes. Please try and stick to time. Thank you very much.
Thank you very much, Hemant, and thanks to organizer for giving this wonderful opportunity to share the dais virtually with Professor Powell and the other dignitaries. So, in next about 15 or 20 minutes, I will run through the key studies which have been presented recently in last ESCO GU as well as ESCO 2022. These are the disclaimers. So, this is the game changer study, first line maintenance evaluate Yavelin bladder 100 study. Professor Powell as well as Minu has elaborated on this study. So, I will quickly run through the couple of slides on this trial. So, in the updated analysis that was presented in ESCO GU this year in February, the survival advantage has been maintained, and there is 8.8 months gain in the overall survival as compared to base supportive care alone. And at the end of 36 months, 36% versus 30% of the patients were alive with evaluate versus placebo. And the same trend we can see with PFS as well, where the HR is 0.54. And what we can see is that this improvement has been maintained throughout the pre-specified subsets, and in practically every subset except patients from Australasia, that may be an outlier. We see the improvement in the overall survival, which was the primary endpoint for this trial. So, long-term follow-up confirmed the improvement in the overall survival as compared to base supportive care. And this was in spite of majority of patients on base supportive care taking one of the immuno-oncological drugs on progression. The safety was maintained, and they support the recommendation of avelumab in the first-line maintenance as a standard of care in our patient. In the same ESCO-GU conference, subset of Asian patient also was presented, where some of us were investigators, and I am one of the author in that poster presentation. So that was about the patient who were treated with the first-line platinum-based chemotherapy, and not all the patients are fortunate to be able to take first-line platinum-based chemotherapy. So 011 study is having pembrolizumab with pembrolizumab and lenvatinib. There are two cohorts of these patients. The first is those who are ineligible for cisplatinum and having a high PD-L1 expression, and the other cohort is ineligible for any platinum therapy. And the previous speakers have tried to elaborate on what do we mean by any platinum ineligibility. One of the consensus statement is coming out from our country as well as the publication in next few months, and I'm sure Bivas and Priya will have a good debate in the end of today's session. But in this particular trial, these were the criteria for any platinum ineligibility: ECOG performance status 2, and one of the following, which is metastasis, creatinine clearance intensity more than or equal to grade 2 audiometric hearing loss or neuropathy or other specified reason as per the case report form. And I am sure not everyone of us will agree to all these criteria. There is a platinum ineligibility cancer working group where any one of these criteria, whether ECOG performance status more than or equal to 3, creatinine clearance less than 30, neuropathy more than or equal to grade 2, NYHA heart failure class more than 3, and ECOG performance status 2 with low creatinine clearance. So this is an evolving science, and let us hope that in coming couple of years we will be very clear about when to give any platinum or when not to give any platinum. So coming back to the LEAP 011 study, platinum refractory, no, platinum ineligible patients or those with cisplatinum ineligible and high PD-L1 expression, the wonder combination of pembrolizumab and lenvatinib did not seem to be working in bladder cancer. At least it worked at many other places, but didn't work here. This is the PFS curve, and this is the overall survival curve. There was no difference between the two curves, so this combination doesn't work here. The sacituzumab is another wonderful drug that has come up in last few years, and a couple of abstracts were presented in ESCO. This is the drug which is targeting TROP2 receptor and having SN38 as the payload, and there is very high payload to the antibody ratio, and payload is attached with cleavable linkage. So this is expected to work well, and actually it works well. The Trophy U01 study was alluded to by my previous speaker, Dr. Srinivas. There were 3 cohorts, and I will be speaking about cohort 1 and cohort 3. And these patients were treated with sacituzumab and pembrolizumab. And we can see that 2/3 of these patients had any shrinkage of the tumor. If you look at complete response rate, 2% of the patient had complete response, 32% had partial response, and 27 had a stable disease. 10 of them were having stable disease for more than or equal to 6 months. So clinical benefit rate was 61% in this trial. So sacituzumab does work in heavily pretreated patients as well. So Tropics 04 is the phase 3 study where 482 patients are planned to be treated, and these are the patients who have progressed on platinum-based and immuno-oncological drugs or platinum in neoadjuvant or adjuvant setting and progressing within 12 months and subsequent CPI. And I hope that the trial will get a good result in next year or so. There is a lot of excitement about PARP inhibitors in practically every tumor types, and so also in bladder tumor as well. So Atlas was a trial of open label trial, phase 2 trial of metastatic urothelial carcinoma without biomarker pre-selection, and it showed that it was acting in some of the patient irrespective of HRD positivity or negativity, but the patient with shrinkage were very small. In the subsequent trial, these are the two trials where niraparib on your left side in MEET Euro 12 study was tried as maintenance therapy in biomarker unselected patient, and the primary endpoint in this trial was progression-free survival, and the primary endpoint was not met in this trial. On your right side, the Atlantis is the trial which is the biomarker selected trial where rucaparib versus placebo were given as maintenance in the patients who had HRR mutation. And the primary endpoint was PFS. And if you read this 35.3, don't get excited because this is 35.3 weeks and not 35.3 months. I would love to look at 35.3 months over here in some of the future trial. But here the hazard ratio is 0.53. Overall survival, you can see that the curve is overlapping for almost 75 weeks, and then there is plateau in the curve with rucaparib, and the placebo curve keeps on declining, and because of that, the median overall survival is not reached for rucaparib versus 72.3 weeks for placebo. So this trial has met the primary endpoint of improvement in the PFS. PIO is the study where the patient who are platinum ineligible, it is assumed in this trial that durvalumab is the standard of care, and this trial compares durvalumab plus placebo versus durvalumab plus olaparib in biomarker unselected patient, and there are stratification as per the HRR status as well as Bayesian risk index. The primary endpoint was PFS. And what we can see in this trial is that in the ITT population, the entire population, without biomarker selection, there was no improvement in the PFS. And if you look at the HRR mutation subgroup, durvalumab with olaparib is having a median PFS of 5.6 months versus 1.8 months for only durvalumab. So it means two things. The first thing is that HRR mutated subgroup is a very aggressive subgroup. With only durvalumab, the PFS is just 1.8 months. So they were supposed to do the second assessment at the end of 2 months, and by the end of 2 months, half of the patients were having progression on durvalumab, and durvalumab with olaparib is having significant improvement in the progression-free survival. The same thing we can look in the overall survival as well with HRR wild type. Durvalumab with placebo is having the survival of 37.7 months, 13.7 months, while durvalumab olaparib has the shorter survival. While with HRR mutated patient, olaparib added to durvalumab is having improvement in the survival with hazard ratio of 0.56. And the same thing in the response rate as well. Particularly, no patient responded to durvalumab with HRR mutated subset, while 35.3, one third of the patient had some response. So, PARP inhibitors are being tried out in the neoadjuvant setting in some of the clinical trials, in the first line in other clinical trials as maintenance, as well as in the subsequent lines of therapy, in addition to other drugs or a single agent. And I hope that in coming couple of years, we will have more information about the use of PARP inhibitors in urothelial cancers. So that was about metastatic breast cancer. I will come back to the metastatic breast cancer in a while. But before that, 3 or 4 slides about MIBC, where cisplatin-based combination is standard of care followed by surgery. And we have one trial of avelumab with other therapy as neoadjuvant therapy. In cohort 1, it was cisplatin eligible patient where either DDMVAC or cisplatin with gemcitabine were given plus with avelumab, and the PCR rate, which was the primary endpoint, was 64% with DDMVAC and avelumab, and 57% with cisplatin gemcitabine with avelumab, which we usually don't see in the patient treated with neoadjuvant chemotherapy. In cohort 2, it was cisplatin ineligible, and then there were two arms, paclitaxel gemcitabine with avelumab or avelumab alone. And in this trial, one third of the patient, 36% of the patient on avelumab alone had pathological complete response, as compared to 18% of paclitaxel gemcitabine and avelumab. And I don't have any explanation about this difference. But if you can see here in this box, there was no treatment related deaths. No patient failed to undergo surgery because of adverse event to the treatment, and there were no major surgical complication and morbidity out of this trial. So it is interesting to see what happens in coming years with this type of combinations. A number of immuno-oncology with chemotherapy combinations are being tried out in neoadjuvant chemotherapy in MIBC, and in coming years we will have the result of this trial. Enfortumab vedotin is a wonderful drug, as discussed by Dr. Srinivas. In cisplatin eligible as well as ineligible patient, in the perioperative setting, this drug has been tried out in a number of trials. But we don't have the result of this trial. What we have is the result of some of the clinical trials where EV103 was phase 1B oblique 2 trial of enfortumab with pembrolizumab, and these were first line cisplatin ineligible patients. 5 patients were in the dose escalation arm, and then dose expansion was in 40 patients. And you can see that 93% of these patients had tumor reduction. So practically every patient who were treated had tumor reduction, and none of the patients had increased the tumor more than 20%. So stable disease or response was seen in practically every patient. EV201 cohort 2 I will be discussing about platinum 9 cisplatin ineligible patient. So these are the patients who were previously treated locally advanced or metastatic urothelial cancer with prior immunotherapy treated patient, and these patients were treated with 1.25 milligram per kilogram of enfortumab on day 1, 8 and 15 of H28 day cycle. And you can see that in this patient, 2 patients were not treated out of 91 patients. Out of 89 patients who were treated, response was seen in 52% of the patient. But what was exciting was that even after previous treatment with checkpoint inhibitor, 20% of the patient had complete response. Partial response was seen in 31% of the patient, and stable disease was seen in 30% of the patient. So 81% of the patient had clinical benefit. EV301, this is the phase 3 study where after failing a platinum-based combination as well as the immunotherapeutic drug, the patients are randomized to enfortumab versus the pre-selected chemotherapy. And in this trial, the previous speaker had shown the curves on the left side at 11.1 months, but in this ESCO, we have the curves for 24 months, and the improvement seen in the previous analysis has been maintained with a slightly better hazard ratio. It is 0.7 for overall survival, 0.63 for PFS, and 13 months of overall survival, median survival, even after platinum as well as checkpoint inhibitor treatment. So this is exciting about this drug. So coming back to the maintenance treatment, so we tried PARP inhibitor. We have already result of avelumab. So whether cabozantinib works here or not. So this is the study of cabozantinib versus placebo as maintenance, and where we don't find any PFS or OS advantage. So this is not a good drug to be used in this indication. In this trial, avelumab alone versus avelumab and cabozantinib has been compared in maintenance of the patients who respond or stabilize after platinum-based therapy, and I hope we will have some advantage over avelumab. So a number of trial, Yevlin medley study is ongoing, where avelumab monotherapy of 800 milligram 2 weekly is the standard of care, and a number of drugs in different arms, sacituzumab, M6223 as well as the MKTR255 are being added to find out whether that improves the outcome, which is already very good with avelumab or not. So this is my last slide, and numerous agents. All of a sudden, urogenital oncology, including kidney cancer, prostate cancer, and bladder cancer, have become very exciting in last decade or so, where a number of new drugs have been showing excellent results as compared to what was there before about a decade. So we have conventional cytotoxic agents with chemotherapy, antibody drugs, conjugate, radiation treatment, we have immunotherapy, where we have checkpoint inhibitors, we have vaccines, we have cytokine adaptive cell-based therapy, and this is exciting. NK cells as well as another cell-based therapy have been tried in advanced cancer as well as the intravesical treatment as well, and other immunomodulating agents are being tried out. And we have a number of targeted therapies. FGFR inhibitors are already approved, and a number of other trials are ongoing with an array of different targeted therapies. So thank you very much for giving this opportunity, and I am staying back for participating in the panel discussion. Thank you very much.
Thank you very much, Dr. Chirag. A very, very nice overview of what is happening in the urinary bladder cancer front. And the advances which are happening are really exciting. And we hope that another breakthrough will happen very soon in the near future. So to continue, we have a case presentation now, which will highlight the issues and problems which we have in our patients in India, and a real world experience. And the presenter is none other than Dr. Satya Dattatreya. Satya is senior consultant medical oncologist at the Renovo Somaya Hospital in Hyderabad. So over to you, Satya. You have 20 minutes. Thank you.
So let me present one of my patients of MUC and how clinical trials can evolve us into clinical practice. These are some of the disclaimers, and part one is about the clinical presentation of this patient who came to me and what was the evaluation we did for this patient. So this was a 59 to 60 years old female who came with painless hematuria, right flank pain, on and off anemia, and recently required RBC transfusions as well around July and June 2021. The ultrasound abdomen on 7th of August 2020, a year back, and then a CT KUB and then a PET CT was done in that first and second week of August in 2021. Let me take you through these three reports. Next slide. 7th of August 2020 ultrasound report showed the right kidney shrunken, heterogeneous, and a dilated pelvic ileal system. They also mentioned about a lobulated, well-defined hypoechoic mass in the left iliac region. And therefore, next slide, the ultrasound specialist made a note that better we do a CECT abdomen. Next slide, please, for further evaluation. So therefore, we got a CT scan done on 12th of August. Next slide, which was around 5 days from this report. And the CT KUB showed that the proximal ureter of the right kidney from the right kidney is dilated with surrounding soft tissue thickening. The lung parenchyma visualized sections also show multiple well-defined rounded soft tissue nodules, and there are multiple retrocaval, aortocaval, and left inguinal iliac lymph nodes. Next slide, please. And so therefore they mentioned that on the CT KUB, there seems to be a growth in the proximal ureter or at the junction of the ureter proximal to the distal ureter. And of course, a note of all those retroperitoneal lymphadenopathy and the lung nodules in both the in bilateral lungs. And a PET scan happened on 16th of August, 4 days after the CT KUB. Next slide showing a right kidney upper pole mass, a right adrenal hypodense nodule. Again, all those RP lymph nodes and the bilateral pulmonary metastasis. Now we wanted to go in to get a tissue biopsy. Fortunately, next slide, we were able to also have left level 4, level 5 supraclavicular lymph nodes. Clinically also it was palpable and hard. And so, next slide, this is some of the pictures of the patient's reports. The left supraclavicular nodal mass, the RP nodes there. The right kidney lesion you can see to your right. Next slide. The iliac nodes above and the bilateral pulmonary nodules in the sections below. So with this CT scan, KUB and the PET CT picture, we then went ahead with the next slide. histopathological examination. And as I told you, next slide, it was easy to approach the left supraclavicular lymph nodal mass, and the biopsy report came as metastatic adenocarcinoma. An IHC was suggested, which was done, showing us next slide. CK7 strong positive, CK20 was focal moderate positive, PAX8 TT1 and CDX2 were negative, P40 were negative. GATA3 was positive. Now, GATA3, as we all know, does come positive in breast cancer, but GATA3 can also come positive in the GU malignancies. So, because the PET scan report mentioned a mass in the kidney, they preferred a primary in the kidney over the mid GI tract. Now, having said that, next slide, we went ahead with a second opinion. When I discussed the pathologist personally, she said that this probably might be a high grade non-clear cell was sent for a second opinion. Next slide. The high power and the low power fields. Next slide. The CK7 positive. Next slide. And the CK20 also positive. Next slide, please. At CK7, CK20, GATA3 also came positive. So CK7 positive, CK20 positive, GATA3 positive, and next slide, CDX2, PAX8, and P63, all three came negative. So in view of this, the second pathologist commented, next slide, that the overall IHC findings favor the possibility of a high-grade renal cell carcinoma non-clear cell type. In the meantime, the urine cytology also was sent. And the urine cytology report, next slide, this is how the urine cytology cells looked like. And so they gave that there could be a possibility of a high-grade carcinoma of the urothelium, possibly of a renal pelvic origin. So next slide, we went ahead by doing further IHC markers. CK7 positive, GATA3 positive. Next slide, PAX8 Vimentin negative, and then HMWCK came positive. In view of this, therefore, the final report was given as metastatic grade 3 poorly differentiated urothelial carcinoma of renal pelvis origin. Next slide. And so let's come to the medical oncology management. The patient was found to be cisplatin eligible. Next slide. And so the patient went on to receive 4 cycles of gemcitabine and cisplatin on 10th of August till 1st of November 2021. After 3 cycles, a CT abdomen showed a partial response, and therefore we went on to finish 4 cycles. At that time, after 4 cycles, a discussion was done about the introduction or the usage of evolumab as maintenance. In the meantime, the family had sent all these lights and blocks for a third opinion as well to Anita Borges, madam. Next slide. So third opinion was taken. Next slide. And the final IHC conclusion came as metastatic carcinoma of the urothelium. So therefore, it was confirmed multiple times that we are dealing with MUC and not with a metastatic non-clear cell renal cell carcinoma. The family wanted some time to decide about, of course they do, but family does need time about the financial implications of an immuno-oncology molecule. So in the meantime, we went on to give 2 more cycles of gemcite cisplatin as well. Next slide. And so the 6th cycle got over. Next slide, please. On 13th of December 2021. By that time, they decided to proceed with maintenance evolumab. A medical oncology colleague of us from America was also known to the family, so he was in a way in a treatment plan as well, and therefore he asked that before starting the first dose of evolumab, let us get a PET CT scan and to have a baseline picture. So at the end of 6 cycles of gemcite cisplatin, next slide, we went for end of chemotherapy evaluation. Next slide. And that's the PET scan report of 27th of December 2021, 2 weeks after the last cycle of gemcite cisplatin. The RP nodes have come down significantly, partial response. Next slide. The right kidney, or rather the right renal pelvis or the ureter lesion, showing a complete metabolic response. The iliac nodes, partial response. Next slide. Now those are the iliac nodes, external and inner, showing a partial response. Next slide. And then above are the lung nodules showing a very good partial response after 6 cycles of gemcite cisplatin. Next slide. So that's the PET CT scan impression showing an overall favorable metabolic and morphological response as per the various criteria. So the patient went on to get, next slide, maintenance evolumab, which was started on 28th of December 2021. It was continued till June 2021. Recently, 3 to 4 weeks back, there was a disease progression after almost 6 months of evolumab. So that was one of my patients of MUC who went on to get standard gemcite platinum based doublet combination chemotherapy as first line, and then did well for almost 6 months or more than 6 months on maintenance evolumab to ultimately progress. Thank you so much, Chairman sir, and all of you have been very patient hearing.
So hi everybody, my apologies, I just stepped out for a minute. Thank you, Satya. We did bring out some really practical issues in our country. Thank you very much. So we'll move on to the panel discussion now. And again, considerations related to everyday practice we will bring out in this. The moderator of this panel discussion is none other than Dr. Vineet Talwar, who is one of the top medical oncologists of our country. And he is also the director of medical oncology at the Rajiv Gandhi Cancer Institute in Delhi, and also a very, very dear friend. So over to you, Vineet. If you could invite your panel and start. Thank you very much.
Thank you very much, sir, for the kind words. And without much ado, may I request my esteemed panelists, Dr. Meenu Walia, Dr. Srinivas.
Yes, sir. I'm here.
So Dr. Srinivas is consultant medical oncologist at HCG Bangalore. Dr. Dattatreya, you just heard. Datta, you are there or still muted? Huh? So you are
Hello,
there.
Dr. Vineet. Can you hear me?
Yeah, Dr. Meenu. Now I can
Yeah,
hear
I am
you.
there. Probably I was
Thank
muted.
you. Thank you so much.
Unmuted.
Dr. Beavis, are you there? Dr. Chirag, I can see you. Thank you. Dr. Priya, are you there? I could hear Dr. Meenu, Dr. Srinivas, Dr. Dattatreya is there, and Dr. Chirag is definitely there. Dr. Powells, so Dr.
And
Beavis and Dr.
is
Priya
there.
is Dr. Priya.
Dr. Priya, I'm here, sir.
Yeah, okay, fine. So we have a full house now. Thank you so much. Thank you. So this is the bladder cancer management by stage, where you find that the chemotherapy drugs and the immuno-oncology drugs have crept from the metastatic setting to the muscle-invasive bladder cancer setting, and now to the NMIBC, that is non-muscle invasive bladder cancer setting. And we have data for the IO drugs for the adjuvant setting as well. So we would be concentrating more on the metastatic bladder cancer. We would be focusing on the cisplatin eligible, ineligible, and the other possible combinations which can be taken care of in everyday clinical practice. So you have three distinct segments in the first line metastatic urothelial cancer. You have the cisplatin eligible, ineligible, and platinum ineligible. So, Dr. Meenu, let me start with you. What is the percentage of patient you see in these segments? Dr. Meenu, if you could tell.
Yeah. Can you hear me again?
Yeah, sure, we can hear you.
Yeah. So cisplatin eligible, I guess only 60 to 70% in my practice are cisplatin eligible, and that makes it almost 20 to 30% who are cisplatin ineligible, and platinum ineligible possibly another 10%, that is platinum ineligible. So till 90% is generally 80 to 90% are platinum eligible.
Okay. Dr. Beavis, do you have any difference of opinion?
Yes, in my practice, the platinum ineligible will be around 20%, and cisplatin eligible will be around 30%, and 50% will be cisplatin eligible in metastatic setting.
Dr. Chirag, any change?
It's about 50, 30, 20.
Okay. So broadly, we agree that platinum ineligible are about 15 to 20%, and rest all are either cisplatin eligible or cisplatin ineligible. That is for carboplatin in this situation. Dr. Srinivas, what all factors do you consider while defining platinum ineligibility? Dr. Srinivas, if we can hear you.
GFR scan, if it is less than 60, or less than 50 ml per creatinine clearance is less than 50 ml per minute, or 30 to 50 ml per minute, peripheral neuropathy, and especially the heart failure, and poor PS. So these are the factors I think will.
So, as you rightly said, these are the factors which we keep in mind whenever we talk of the eligibility, whenever we are sitting in our OPDs. Dr. Datta, do you routinely check GFR whenever you come across metastatic urothelial cancer patients, and why? If he's not there, I think.
Yes, sir. Dr. Srinivas,
Yeah,
sir. Yeah, we
yeah.
routinely check any patients for cisplatin. If you are planning, definitely we check for GFR patients.
So, how do you check it? Do you check it by EGFR, or you do the radionuclide scan, that is the
Radionuclide study.
DTP?
Radionuclide study, sir.
So practically for all patients, you do the radionuclide
Yeah,
scan for
most of the
checking the
patients. Yeah.
right.
Yeah.
Dr. Chirag, next slide, please. Do you routinely check PDL1 testing upfront in patients of metastatic urothelial cancer?
So if the patient is the so my simple answer is no. I don't because if the patient is the platinum cisplatinum eligible, there is no need of checking PDL1. If the patient is the carboplatin eligible, then based on the in bladder 100 study, they give carboplatin gemcitabine, and if the patient is affording, then
No, that's
they
okay.
give
What I
available.
meant to ask was that
Yes, the
upfront
answer is
at
no,
baseline, generally you don't do.
no, no.
Any other thoughts, Dr. Beavas?
No, so we don't check PDL1 upfront simply, and I don't check EGFR. I mean DTP EGFR also. Just
No,
calculate
I'm
with
talking about
EGFR.
the PDL1 testing.
No, no.
You don't do it. Dr. Srinivas, do you think it is of some prognostic importance in bladder cancer per se?
No, as such, I think usually we don't check in the first line, but only patients are not eligible, then only we check.
Fine.
Otherwise, because most of the frontline immunotherapies are not given good ones, so I think only in the
So
second
I
line.
think we have a consensus. It is not routinely checked upfront, and wherever you find that there is ineligibility of platinum, then probably this comes. Yeah, next slide, please. So this patients who are in cis ineligible, these are the ones in which we take. Next slide, please. So, Dr. Priya, what are your thoughts on the correlation between the FGFR alterations and poor responses to immunotherapy? So, if you have a FGFR alterations, do you think that would you give these patients immunotherapy upfront in those patients who are ineligible?
Hello, Dr. Vineet, Dr. Tom is online right now. Dr. Pauls has joined.
Okay, fine. So, Dr. Priya, are you there?
Yes, sir, I'm here, sir.
Yeah.
Sir, so frankly, I'm not doing FGFR alteration yet. I have yet not done in any patient. I'm just doing broad sequence NGS where I have not seen these mutations. I don't have
Okay,
much idea about these correlation.
fine. Because okay, let us ask Professor Pauls.
Yes.
Could I get your thoughts on this
Yeah.
correlation between FGFR alteration and poor responses to immunotherapy?
Yeah. So we don't know that. And FGF alterations are not a biomarker for immune therapy, to PD1, PD-L1 therapy. In the same way as PD-L1 is not a great biomarker, FGF is not a great biomarker. Now, of course, there may be some patients with FGF alterations that don't respond. And we know from our TCGA analysis that the FGFR DNA alteration patients tend to have more luminal than basal cancers. But we also know that there is a broad spectrum of both luminal and basal cancers that respond to immune therapy. Now, I'm prepared to have the discussion around this, but it's also worth noting in the Norse trial, in those patients who have FGFR alterations, the response rate to erdafitinib plus atrilimab was 68% and was only 33% to atrilimab alone. What this means is that clearly there are some responses to immune therapy for patients with FGF alterations. So I would summarize this story and say, just as with PDL1, other biomarkers, FGF in its own right doesn't define response and resistance.
Thank you so much for clarifying this doubt. The next question would be to Dr. Chirag. The next slide, please. What percentage of patients reach the second line chemotherapy?
So if I have 100 patient eligible for first line, I think 90 will take it. But out of those 90, almost 50 will be taking second line treatment.
Right. Dr. Srinivas, any different thoughts? Next slide, please.
Yeah, I think around 30% of the patients only will reach this.
Okay, so you have 90-30. Let us see Dr. Beavers, or if he's not there, Dr. Meenu.
Yeah, just 40, but why 30-40% patients only will receive the second line.
Priya, what is your thought?
So I agree, not more than 30 to 40%. Yes.
Okay, so say about 40% patients reach the second line. So there is an attrition of about 40 to 50% of patients whenever they go from the first line to the second line. So if this area can be expanded as a cohort, then probably we can translate into a better quality of life. Next slide, please.
I think the other point with that is that you get one good go at treating metastatic bladder cancer. And I think there will always be patients who never get second line therapy. And so I think selecting the right first line therapy, treating patients appropriately is a really important message because we only get one good go at this.
So you also experience about 1/3 of patients who progress from the first line to the second line as far as the therapy is concerned.
Yeah, we did an audit of our cohort recently, and about
Right.
half the patients never get to second line therapy. And it's because the cancers are growing fast and they just never get in control of the disease.
Right. Dr. Srinivas, if you give chemotherapy only, I mean, these are all clinical situations. So what is the OS do you observe with the only chemotherapy in your clinical practice? Dr. Srinivas, are you there? Or Dr. Beavers?
Sorry, I missed the question, sir.
Yeah, the question is, when you give chemotherapy, what OS are you expecting in first line? Only chemotherapy.
Overall survival, sir.
Yeah.
Overall survival may be around 10 to 15 months.
10 to 15 months. Right. Dr. Meenu, what is there in your practice?
Yeah, same 12 to 15 months.
Chirag, you want to have a different opinion or same?
No,
So,
same. Yeah.
yes, I think all of us are correct. We have about 1 to 1.5 years of overall survival whenever we talk of the first line. Next slide, please. If you combine chemotherapy with the immuno-oncology drugs in the first line, do you think there is any data to support it? Dr. Dattatreya, are you there? Or probably Dr. Priya can take it?
Sir, there have been at least 2 trials regarding atezolizumab as well as pembrolizumab, the 3-arm studies where there have been the combination, but they have not improved the survival figures.
Yeah, next slide, please.
Combination.
So you're right. There are 3 trials which have been there in this setting. Chirag, you wanted to say something?
Yeah, for atezolizumab, we don't have mature data as of now. For pembrolizumab and for durvalumab, it is not improving the survival.
So you are right. May I ask Professor Powells, when you have these 3 trials in which logically when you should add chemotherapy drug to immuno-oncology drug, it should have a benefit. what could be the reason that the addition of IO plus CT, like the other organs, it just had a probably a PFS benefit when it was the IMvigor 130 trial? Professor Pauls,
I think the PFS benefit in the InVigor 130 trial was fairly modest. I
very
think,
modest, yes.
and I think all of these trials, the curves only go apart when the chemotherapy stop. Remember, they're not chemotherapy combination trials. They're chemotherapy combination trials followed by maintenance immune therapy trials. And the curves only go apart when the chemotherapy stops. We were very concerned when we started this journey that giving chemotherapy with immune checkpoint inhibitors would potentially be counterproductive because of antagonism associated with the immune suppressive effects of chemotherapy. We then got the lung cancer data, which didn't show that. But actually, the difference is that we use different, less myelosuppressive chemotherapy in lung cancer. And it might be, unfortunately, the really immune suppressive chemotherapy that we use in urothelial cancer is holding the immune therapy back in this disease. It might be possible that using other combinations in the future, and that includes the CTLA4 combinations from an immune therapy perspective, but also the antibody drug conjugates rather than GEM-CIS or GEM-CARBO from a chemotherapy perspective, may turn out to be synergistic in the future. So I think we need to learn more about this space, but it's clear that in bladder cancer, GEM-CIS or GEM-CARBO are counterproductive.
Right. Thank you very much for giving the clarification. So we move ahead now. Next slide, please. So when we have seen that chemotherapy alone dishes out about 10 to 15 months, and the combination of chemo and IO does not work, then the next obvious strategy would be chemotherapy followed by some kind of maintenance treatment. And next slide, please. And that led to this approach where you give the maintenance therapy and try to expand the first line cohort so that you get the benefit, the quality of life, and also the survival. And this was the schema which already has been alluded to you. And these are the progression free survivals in the overall population and PDL1 positive populations. Find there is a difference. So this was the overall survival also. So you see that you go from a dismal 10 to 12 months to about 18 to 20 months, which has been aptly shown by Professor Pauls in this study, and this is a landmark study. So, Dr. Chirag, do you look at patients with specific response rates who would benefit from first-line maintenance therapy? Next slide, please.
No,
CR, PR,
because
SD, or would you club all of them for the treatment?
so we can club all of them together because in this year's ESCO GU 2022, they had the updated analysis of whether it is CR, PR, or stable disease. The benefit is equal to all the subsets.
So this is what
Yeah.
Dr. Chirag has alluded. Dr. Powell, any comments from your side? So, Dr. Minu, for patients with bladder cancer who are cisplatin ineligible, but otherwise eligible for platinum agents, would your standard treatment be gemcitabine plus carboplatin followed by avelumab maintenance, or would you think for something else? Dr. Minu,
Hi,
I
it's
think,
Tom. I'm sorry, I was muted and I was finding it hard to unmute myself.
No, I
okay.
will think of gemcitabine plus carboplatin only. If cisplatin ineligible,
Mhm.
hello.
Yeah, fine. So you will think of avelumab maintenance in this case?
Yeah.
Yeah.
I'll
Next slide, please. Professor Pauls, sorry we lost you in between.
My fault.
So, yeah, so the question was for patients with bladder cancer who are cisplatin ineligible, next slide please, but otherwise eligible for platinum agents, would your standard treatment be GEM plus carb followed by avelumab maintenance? Can I have the next slide please?
Yeah, so I think the answer to that question is that is the right approach.
Agreed. Now I make a twist in this. What
Yeah,
if they were PDL1 positive? Would you still go for that, or would you go for the IO?
yeah, I don't really believe the biomarker works, and so I wouldn't be using the biomarker to select patients. I completely understand those people who want to use immune therapy for some patients, but I don't think anyone who I've met genuinely feels the PDL1 biomarker is the right way to select those patients.
So I think there is a clarity here. Uh, there is always a benefit, whether it is GEM cis or GEM carb, followed by the avelumab maintenance, which has shown a stark improvement in the overall survival in this cohort of patients, and which has been nicely explained by Professor Pauls.
So Vineet,
Yeah,
may I request you to wind up in 1 or 2 minutes, please? Thank
sure,
you.
sure, sir. Sure, sir. So Dr. Minu, this is to you. How soon would you like to start avelumab post chemotherapy? Do you want to wait for 4 to 10 weeks as per the Javelin study, or would you start immediately?
So we normally wait for almost a month, almost 4 weeks. And anyway, after the chemotherapy, you are re-evaluating. That we normally do after a month only and then start the patient.
Chirag, any difference?
No, I absolutely agree with Dr. Mino. But my question is that if we just missed to start Evolumed by 10 weeks, if the patient is at 11th or 12th week, the question is for Professor Powell's, whether we still consider Evolumab or we don't.
So, Professor Paul, the question is
I, I
12 weeks. What
yeah,
would be the actual cutoff?
I think the actual cutoff from a trial perspective, from those purists amongst us, would say is that it is that 10-week cutoff is where the label lies. I think, in my opinion, for the vast majority of patients, the sooner we start, the better. But I also firmly believe that there's nothing magic about that specific time point. And in the same way as I don't think that Evaluab is a lot better than pembrolizumab, I also don't think 9 weeks is that different from 11 weeks. I think the principle that for those patients whose cancers are not growing, they're better off starting immune therapy earlier than later. And therefore, I wouldn't wait till the cancer starts growing back before starting therapy. The reason why that's the case is when the cancer's growing back and you can see it growing, for most patients, it's too late.
So,
Thank you.
thank you, Dr. Pauls. Next slide, please. So, this is the long-term follow-up, which has shown that there is a significant improvement in the OS and the PFS. Next slide, please. So, I think we would have continued, but because of the paucity of time, I think I will stop here. We can have the last slide. So, this is the best combination which we have discussed, and that is what our esteemed panelists have shown, that if you are given a choice of chemo only, chemo plus IO, or chemo followed by maintenance IO, the best way to do would be chemotherapy plus maintenance IO. So, next slide, please. So, with that, I think we'll come to end of this fruitful panel discussion, and I thank my esteemed panelists for joining me here, and also Professor Paul for clearing the doubts and the clinical scenarios wherever we get stuck. So, I thank you very much for your patient hearing. Thank you so much.
Thank you, Vineet. Thank you very much. Very important, very practical, very relevant points brought out. Thank you all the panelists. So we move on. We're about 10 odd minutes late, but that's not bad for a multi-speaker session. And it's my pleasure and privilege to invite Dr. P.K. Julka. Dr. Chulka has been a friend for 30, 40 years now. He is presently Senior Director, Max Oncology Daycare Center at the Saket, Max Saket. And he is also ex-dean and professor of oncology at AIMS New Delhi. And Dr. Julka will take us through a very nice debate between two top medical oncologists, and I'm really looking forward to that. Over to Dr. Julka.
Thank you very much, Dr. Hemant. I think we are coming to an interesting debate of we have already talked about the various aspects of GU cancers and what is the best strategy for management of cisplatin ineligible patients. Is it gem carbo followed by IO maintenance versus IO monotherapy? And we have two stalwarts, Dr. Beavis from Tata Memorial Center, Calcutta, and Dr. Dheeraj Padi raised the motion. So let us have Dr. Beavis for the motion. Dr. Beavis, please.
Thank you, sir. Thank you for the introduction and very good evening to everybody. And thank you, the organizer, for giving this opportunity. So Priya is my dear friend. So I have the liberty to present first, and then Priya will defend that. So my topic is to defend whether GEM carbo followed by IO maintenance is the best strategy for cisplatin eligible patient versus IO monotherapy. Next slide. Yeah, so what is the rationale behind this immunotherapy maintenance? There are several factors that contribute to the biological rationale for benefit of IO maintenance. No. Previous slide, please. Stick there. Previous slide. Go to back to the last slide. No. Slide number 3 or 4, the first one. Can I have the control? Yeah. So there are tumor-related factor and there are chemotherapy-related factor. One is that we know that urinary bladder cancer is one of the immunogenic tumor. Next slide. So the immunotherapy has been demonstrated to get activity in tumors with a high mutational burden, and we know that bladder cancer is one of the immunogenic tumor. On the other hand, the chemotherapy has a cytotoxic and immunogenic effect on tumors. It promotes tumor immunity because of the cell killing. There is a lots of neoantigen production, neoantigen presentation, and MHC activation, and that leads to more binding of this PD-1 overexpression and the synergistic activity or the potential activity or increased activity of this immunotherapy and chemotherapy. Yeah, so this is the immunogenic potential of the many tumors you have seen from starting from the right side to the left side. First is the melanoma, then two types of lung cancer, squamous and adenoma, followed by bladder. So bladder is fourth in that ladder of with a high PD-1 expression and more immunogenicity because of the, and also there are DNA damage response mutations, and that leads to formation of immunogenic new antigens. And so it has been shown that the starting from the adjuvant use of BCG in the early stage bladder cancer, we know that it is one of the immunogenic tumor, and on the potential blockade of the immune potential that leads to the higher cure rate of bladder cancer. Same thing we have been seeing in the stage 4 cancer. We have data on second line setting also that the immunotherapy works very well. Now the immunotherapy moving to the first line setting. So there is a clinical evidence support that anti-PD-1, anti-PD-1 antibodies works in second line and also in first line in cisplatin eligible patient also. So this is the response rate in a cisplatin eligible patient with a high dose MVAC 64%, 50% the GEM-CIS, and for cisplatin eligible the modified MCAV is a 30% and GEM carbo is 41%. So if you see the response rate, GEM carbo or GEM-CIS, not much of difference, 41 and 50%. So the clinical evidence suggests that IOs are more effective in patients with reduced tumor burden. So this combination therapy in a cisplatin eligible patient, GEM-CIS, the MVAC leads to higher response rate, so the immunotherapy will works better. But even on the contrary, for a cisplatin ineligible patient, even if you use GEM carbo, there is a 40% tumor reduction. So the immunotherapy should better works well once the tumor get responded to the chemotherapy. So the CT agent, the chemotherapy used in typically in bladder cancer also promotes an environment that may allow for the greater activity immunotherapy. So these are the different chemotherapy agents that we use: gemcitabine, carboplatin, cisplatin, and taxane. Now, which one? The gemcitabine depletes the immunosuppressive cell types. Carboplatin induces immunogenic cell death. Since both the platinum is augments the molecular changes for providing a direct target for the IO agent, and the taxane, cisplatin, and gemcitabine, they increase the expression and the presentation of the tumor antigen on the cell surface with a higher production, the higher MHC upgradation and the higher PD-L1 expression, and that leads to increased activity of the anti-PD-1 or anti-PD-L1 monoclonal antibody. So the IO maintenance therapy may also allow for synergistic anti-tumor activity between the agents, thereby extending the clinical benefit of platinum-based doublet chemotherapy. So the initial platinum-based doublet chemotherapy leads to tumor shrinkage, decrease the tumor burden, and also at the same time make the tumor more immunogenic because of the cell destruction and apoptosis more antigen is produced and more neoantigen expression and PD-L1 overexpression so that the IO can work better. So the IO maintenance maybe works better rather than a second line use. So the maintenance therapy with IO has the potential to maintain and extend the benefit of the first line chemotherapy in patient whose disease has not progressed. So disease is controlled by the initial chemotherapy regimen. So the patient initiate IO with a lower tumor burden, as I discussed. Patients who have responded to chemotherapy are more likely to benefit for immunotherapy, and only patient displaying this clinical biomarker receives early immunotherapy. A period without chemotherapy prior to IO initiation, that means if you delay the immunotherapy much longer after the chemotherapy is over, it has been hypothesized that it's remove the selective pressure of the chemotherapy, which may lead to re-expression of the drug targets and intensify the elimination phase. That is the decreased tumor volume. And the immunotherapy activity may not be that great versus if you start the chemotherapy immediately up, start the maintenance immunotherapy immediately after chemotherapy when the tumor burden is very less and there's lots of new antigen production. So the maintenance therapy may delay the need for an alternate next line therapy, expanding the therapeutic options within the continuum of care because we are switching the patient from upfront chemotherapy to immunotherapy. So there is a clinical rationale for Avalua maintenance as first line standard of care, as we discussed the Javelin 100 trial in details. Next slide. So the next slide, please. We know about the very poor dismal outcome of the patients with bladder cancer in advanced setting. So these are the guidelines we know about advanced endometrial cancer. For locally advanced or recurrent metastatic UC, cisplatin eligible, use the cisplatin gemcitabine or the MVAC. And if the disease is not progress, go to the Avalua maintenance. For a cisplatin eligible patients, use gemcitabine carboplatin followed by Avalua maintenance without any disease progression. So this is a clinical practice. Majority of the patients who are in a bladder cancer received cisplatin based therapy. So the blue one is a cisplatin base, the green one is a carboplatin base, and there are 10 to 15% patients who are ineligible and receives other treatments. So this is the data from US, UK, and Germany. So this is almost in line with our clinical experience that most of the patients do take platinum, either of the platinum and mostly the cisplatin. So the platinum-based chemotherapy associated with shorter OS and median PFS. We know the median OS is around 14 months with gemcitabine cisplatin and median PFS around 2 to 3 months. And this is about MVAC. So you know that the outcome with chemotherapy, both the median PFS and median OS is not that great. Usually it varies between 10 to 14 months depending on the different chemotherapy regimens. And of course with the cumulative drug-related toxicity. Next slide. So what are the treatment approaches, including in the maintenance therapy? There are two approaches: is the immunochemo combination followed by IO maintenance. I think the two of the clinical trial, both the Keynote trial and the Danu trial, failed to show the benefit of chemo IO combination upfront. And we have the Javelin trial so far that is only approved that IO maintenance after initial chemotherapy in patients with non-progressive disease improves the overall survival. The Nile study data is still awaited with the IO chemo combination, is a 3-arm design. And other than those patients who are not receiving immunotherapy, the standard treatment in a research support setting is that you give chemotherapy, stop the chemotherapy after 4 to 6 cycles, you wait for progressions, and once they progress, then you start the second line therapy, either cytotoxic chemotherapy or immunotherapy. But if you see this curve, that most of the patients who received IO maintenance therapy had the cumulative better overall survival. Yeah. So this is the trial design. We know it was a randomized study after the patients received 4 cycles of platinum-based chemotherapy. In case they 4 to 6 cycles, in case they don't have any progressive disease, and this is the outcomes. This is a median OS and median PFS. There's a clear-cut benefit of both PFS and OS as compared to chemotherapy alone. And this is the result. The result is much better if you do the subgroup analysis in patient with PD-L1 positive tumor. In the median OS is not reached in patient with avelumab group versus 17-month patient with best supportive care group, and also the median PFS 2.1 versus 5.7 hazard ratios pretty very good, 0.56 here and 0.56 both. So there is almost 40 to 45% reduction in both progression and death in patient with PD-L1 positive tumor if they receive avelumab maintenance. So this is the more common IRAE. We know how to manage them. Is mostly either the pneumonitis or transaminitis and endocrine toxicity. But definitely, if you see the grade 3 toxicity is very less than 1%. except the asymptomatic lipase amylase increase. So summary of the clinical rationale for available first-line maintenance is that if give the first-line chemotherapy, if the patient has either complete response or partial response or stable disease, you switch to IO maintenance and they do well on IO maintenance. And once they progress, then you move to second-line therapy, either cytotoxic chemotherapy or other target therapy or clinical trial or FGFR therapy, if they're FGFR positive. This is in a nutshell of current standard of care in patients with metastatic urothelial carcinoma. So definitely there is a high probability of achieving disease control after gemcitabine carboplatin-based therapy also in patients with cisplatin-eligible patients, and they do respond so well very well to IO maintenance therapy. There is not a big difference between overall survival in patient who received cisplatin versus carboplatin. For a cisplatin-eligible patient, gemcitabine carboplatin followed by IO maintenance, and also those who has a PD-1 positive tumor leads to very good overall survival so far. So thank you very much. Thank you for giving these opportunities. I invite Dr. Priya for his deliberation. So back to Dr. Chulka. Thank you, sir.
Thank you, Dr. Beavis, and for an excellent talk on that chemotherapy is essential as a first line, followed by IO maintenance, which we have seen in the Javelin trial, which we have seen in most of the trials. Now I shall invite Priya to talk against the motion, and let us hear Priya what she has to say on IO as a therapy, main therapy.
Thank you, sir. Excellent comments from Dr. Vivas. The thing was that in the previous panel discussion, this question was straightway asked. Dr. Powell also said, "Okay, no, I'll be going with the data of Javelin trial." So I felt there was a consensus there. So that had made actually my task difficult. But I do see that there is a place. I do feel that there is a place of what I'm going to discuss next. Okay, so next slide, please. Next, please. So we have had this discussion that PD-L1 and the PD-1 mechanism is responsible for propagation of many tumors, leading to even the metastatic setting, and the inhibition of these pathways can cause tumor suppression. So just be very clear about what defines, this was again discussed previously, cisplatinum ineligibility and the platinum ineligibility. So cisplatinum ineligibility, we are clear, EGFR less than 60, poor performance status, and yes, you should also do an audiometry evaluation. And if there is a grade 2 or more audiometric hearing loss, then again, should not give cisplatinum. Peripheral neuropathy, and yes, if the patients can't tolerate fluids, they have inadequate heart functions, then again, that is all qualifies for cisplatinum ineligibility. Platinum ineligibility is comparatively a newer terms and still a lack of consensus. But yes, again, a very poor performance status, a creatinine clearance of less than 30, peripheral neuropathy of grade 2 or more, heart failure class of NYHA class 3 or more. Now, also creatinine clearance cutoff. Yes, creatinine clearance cutoff of some say less than 30, some say less than 60 with performance status of 2. So that brings us that now since we have a clarity of definition, 50% of patients will be cisplatinum ineligible, and around, as discussed in the panel also, around 20% will be actually platinum ineligible. So what we need to find out, what is the best approach for both of these groups. So this is where the IMvigor 210 study, the data came, also discussed previously. Now this was a single arm phase 2 study with 2 cohorts. We'll be focusing on the cohort 1, where the previously untreated cisplatinum ineligible patients were taken. 119 patients and atezolizumab were given once in 3 weeks. Primary endpoint of overall response rate. Now we do understand this is a slightly weaker endpoint compared to the other endpoints of PFS and OS. So it was an open label study, locally advanced or metastatic urothelial cancer patients were taken. Now, this study used a PD-L1 measuring method using the ISC of SP142, and the problem is they just measured immune cells. Now, sometimes we have and across all the tumors, we hear about the TPS score, CPS score. This only had in immune cells. And this is one of the problems with the urothelial bladder trials, that there's a lot of heterogeneity between how the scores are being, how the PD-L1 scoring are being measured. And that might also lead to heterogeneity of the results. And of course, making the cross-trial comparisons much more difficult. So this is what done here. So what the trial showed that, and what it led that in the May 2016, atezolizumab was approved by the FDA for the first line using the cisplatinum eligible patients. What happened? The primary endpoint, overall response rate, when it was compared, it was around 24% in the IC23 population. But in IC10 population, it was slightly lower. So overall response rate slightly better with the, and it correlated with the IC expression. But when they did an overall survival analysis, actually it was slightly better in the IC01 population compared to the IC23 population. So we got a slightly discordant results there. So atezolizumab approved by, and the overall survival was around 15 months. So atezolizumab was approved by the FDA for the first line use in cisplatinum eligible patients. Again, however, with the subsequent trials and also for the trials of the pembrolizumab that we'll be seeing, since the differences in the PFS and the overall survival were not markedly different, the approval was restricted to the cisplatinum ineligible patient with the PD-L1 positive tumors or the patients who are not eligible for any platinum containing chemotherapy regardless of the PD-L1 status. So again, the pembrolizumab and atezolizumab were originally approved by the FDA for the first line use in the cisplatinum ineligible patients. However, in light of the poor survival in the patient with the low PD-L1 expression in the Keynote 361 and IM VGOT 130, this has been revised. So because the survival results were slightly comparable and not that great in the low PD-L1 expression. So not eligible for the cisplatinum containing therapies and whose tumor express PD-L1 above a defined cutoff, maybe there the results are better, and that is the group where you can use. But the important thing is that we are yet learning about how to use PD-L1, what is the best way to your best method to measure PD-L1 and how to define the cutoff where we can find the most accurate results. And not eligible for any patients where you can also use, we're not eligible for any platinum containing therapy regardless of PD-L1 status. Next, please. Now, just to just slightly open up the results of the pembrolizumab monotherapy Keynote 052 study. 370 patients, again, an open label advanced urothelial cancer patients. So again, here the PD-L1 status assessment was done by the DECO PD-L1 ISC 22C3 method. Now again, we see that yes, there is a difference in the PD-L1 measurement. And the primary endpoint is overall response rate like the IM VGOT 210 trial. Next slide, please. So what we see, the response rates of 34%, small median PFS of around 2 months and 6 months overall survival of around 67%. So again, the first line cisplatinum eligible patient, this offers a valid option, especially if the patients are again not even able to receive carboplatinum. The important things in our setting, lot of patients, they will be unwilling to receive chemotherapy. All these trials, you have lot of patients who are elderly, who already have lot of comorbidities, which make the monitoring of the side effects as well as the treatment-related side effects a major problem. So there is this gaps is actually filled by the usage of immunotherapy monotherapy. Next, please. So this brings us to the Keynote 361 monotherapy arm, 1,000 plus patients. And here again, we have 3 arm study, pembrolizumab plus chemotherapy and gemcitabine plus chemotherapy, gemcitabine and cisplatinum or carboplatin, the chemotherapy only arm. So we'll be focusing among the comparison of arm B and arm C. So what was presented in the ASCO 2021, that in this exploratory analysis, pembrolizumab was associated with a longer duration of response than chemotherapy in choice of carboplatinum patients, but median overall survival similar between the 2 treatment arms. Next slide, please. Yes, so this was again a 3-arm study. Please go to the next slide. So what we see, and that the duration of responses are higher in the patients who are taking immunotherapy. But the important thing is with chemotherapy, the overall response rate is higher. That is what we see here.
So I think you are destined not to finish your slides, Priya.
This is actually Pfizer's meet. So that is what is happening, I think. So the pembrolizumab was associated with a longer duration of response and chemotherapy regardless of the CPS score also. So you can see the CPS more than 10 and also regardless of the CPS score. Please, the next slide. Yes. So additional evidence of pembrolizumab monotherapy if we are discussing comparing the overall survival. So when you see here for the total patient population, we see nearly the overlapping curves followed by again later on some kind of divergence. So 14.6 months versus 12.3 months. And if you have a higher CPS score, it is 15.6 months versus 13.5 months. So what is seen is that although overall survival with pembrolizumab was not markedly different than chemotherapy, regardless of the PD-L1 CPS score. So that is why it's very important that you need to choose your patient carefully. But yes, because we also see that the immunotherapy monotherapy is also showing nearly equivalent results across many subgroups, and hence it has a role in this patient population. Next slide, please. So again, just to emphasize, the pembrolizumab, the atezolizumab were originally approved by the FDA for the first line use in the cisplatin ineligible patients. However, in light of the poor survival in patients with the low PD-L1 expression in Keynote 361 and IM Vigor 130, this has been revised. The FDA approved for the both drugs now state that they can be used for the patient not eligible for the cisplatin containing therapy and use tumor express PD-L1 above a defined cutoff or not especially for the from that atezolizumab, the IC score of 5% or more, are not eligible for any platinum containing therapy regardless of the PD-L1 status. Next slide, please. So this was very beautifully pointed out, the comparison of various immunotherapy trials, the monotherapy versus the first line maintenance. I won't be going into the details. So it especially adds to the option for patients unfit for chemotherapy and is a reasonable option for patients who are cisplatin ineligible. We see many durable responses. It improves quality of life over chemotherapy and adds to better tolerance. Biomarkers do help in treatment decision making, but yet we are yet to find an accurate marker predictive response. So that will be all from my side. Thank you.
Thank you, Priya. I think you have defended it very well.
Sir, actually, few of the slides I was not able to run. They were the trial of atezolizumab 130, that IM Vigor 130. So that whole discussion was left, especially regarding the high PD-L1 part. But there were some problems in the presentation. But okay.
In between, there was a blackout actually.
So so few slides we were not able to run. That's regarding especially the high.
Never mind. It was very well done. I think debate was very well conducted. And if we have any questions from the floor, we can take one or two questions.
I think Dr. Julka, let's not do any more questions. We are pretty late in the day.
Since we are running short of time.
And I'd like to thank Dr. Julka for conducting this debate and the two very nice debaters. On behalf of the organizers, we apologize for the technical glitches. We have one angry young lady, I'm aware of that. But anyway, it happens sometimes. So if I were to conclude just 2 more minutes, I know that I stand between you and dinner and maybe a Saturday, Friday evening drink. So we've had a very good session, and you know, the whole gamut of treatment which is now available for urinary bladder cancer has been discussed. Most of the clinical scenarios have been discussed. And Dr. Julka would agree with me that when we started oncology some 30 or 40 years back, we had hardly any options. Chemotherapy, you know, used to be the MVAC kind of chemotherapy and only in the metastatic setting.
Yes.
Now you have very advanced chemotherapies in the neoadjuvant setting, also in the adjuvant setting. The intraluminal treatment other than BCG has now advanced from BCG, you know, evolved to mitomycin, gemcitabine, and now intraluminal taxanes. And we have a whole bunch of new drugs, the checkpoint inhibitors, which are coming up in all the settings, in the metastatic setting, in the adjuvant setting, in the maintenance setting. And our speakers have very eloquently taken us through the present role of these agents in urinary bladder cancer. So it's my pleasant duty to thank all the speakers, especially Dr. Thomas Powell, our international speaker and one of the world's leaders in Euro medical oncology, if I can call it that. And then all the speakers, starting from Dr. Minu Walia, Dr. Srinivas, Dr. Chirag Desai, and a wonderful panel conducted by Dr. Vineet, and two very fine debaters. And I think we've had a very useful day one of this genitourinary tumors conclave, and we expect even more knowledge gain to happen on day two, which is tomorrow. So with these words, I'd like to close the academic session Thank you again. Thank you, everybody.